Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. In this broadcast we're going to be looking at sports medicine. With the programme today we'll talk with Dr. Carmel Goodman and Dr. Rod Moore, both sports physicians. First up, Dr. Goodman spoke with Dr. Olga Ward about the management of chronic conditions within exercise and sport, in particular asthma.
Carmel, welcome to the program.
Thank you very much.
In general practice, we manage an awful lot of chronic disease, but the sporting arena doesn't always figure large in our imagination until the patients appear in the emergency department bleeding or sprained. In terms of actually helping our patients with their exercise at all levels, could you talk us through, for instance, asthma and managing both exercise-induced asthma and also the chronic asthmatic who is starting to play sport at the beginning of the hockey season or the tennis season?
Sure. Well, I suppose from my point of view, quite a lot of asthma at presentation to myself is undiagnosed. So by that I mean they don't present with the classical asthma symptoms, shortness of breath, coughing with exercise and so on, but may simply present with fatigue during exercise, or in the case of the swimmers, particularly as we're seeing more recently that there's more and more chlorine in the outdoor pools, and we're recognising that a lot of potential asthmatics are becoming asthmatic when they swim in the pool. So any athlete or any person that presents to me with fatigue or coughing, or obviously the classical asthma symptoms, the easy test to do obviously is the normal peak flows and so on that we've all got in our surgeries, which probably pick up maybe 30% of asthmatics. If we're talking about exercise-induced asthma, really the only way to do that is to measure FEV1 pre and post exercise. We probably don't need the sophistication of the respiratory labs to do that. So what I simply do is I would measure a peak flow or an FEV1 in my office, send them out to the local footy field, get them running a few laps, or to the pool, get them swimming up and down until they reproduce their symptoms, and then they come back to my room and I measure the FEV1, for about 20 minutes post-exercise. And
so is that something we could actually get our practice nurses to do with most general practices, or many have sort of basic spirometry facilities, so that would be something we could do.
Definitely, I would think so, and when the asthma inhaled asthmatics, anti-asthmatics were initially banned, in the Olympics and so on, the testing to prove asthma became more and more sophisticated. So whereas I used to practice simply pre and post exercise for the elite asthmatics, we got more and more used to using the pulmonary labs. But as I say, I certainly think one can be as effective in one's rooms measuring pre and post exercise peak flows.
So with your exercise-induced asthma, do they need anything other than a reliever before exercise?
Well, normally I think what I've come to the conclusion is, and most of the respiratory physicians I think would agree, is a combination of a long-acting beta agonist and a corticosteroid. And the newest ones on the market function both as preventers and relievers. For instance, the budesonide formoterol combination seems to be as effective as taking any formal preventers. So I would simply say to the asthmatics, as long as they take 2 puffs in the morning, 2 puffs in the evening, starting at a lower dose, that usually controls them. If they need to take, in addition to that, Ventolin pre or during exercise, then one simply increases the dose. And there are very, very few exercise-induced asthmatics that I can think of that aren't controlled to that regime. So I think that's simple, easy, and I don't think one needs formal preventers.
Okay. When our patients, as they sometimes do, head on to a more elite level, like they're trying out for the state team for hockey or something, is there anything we need to be aware of, particularly if they are a very chronic asthmatic, or I'm thinking particularly the wheat belt during harvest, and really from September when the wildflowers are blowing pollens everywhere, they quite often will need a short course of oral steroids. Is that going to screw things up for them?
From a drug testing point of view, yes, because the oral corticosteroids are banned. So if they're an athlete that's eligible for drug testing, they're not actually allowed to take the oral steroids unless obviously one can get permission beforehand. So if you can document that they need it for maintenance, or if they're at death's door and you have to give it and retrospectively, you know, can explain that it was an emergency. But probably the only other thing that I would use in terms of any of the, in addition to any of the anti-asthma medications, would be antihistamines. You know, so when you talk about both if there's extra dust in the air, or again, coming back to the swimming pool with the chlorine, I would use something like Claritin or any of the antihistamines in addition to the anti-asthma medications.
Okay, and the chlorine effect is allergy or irritant?
Probably both. And we never used to think, and this is another whole...
We always used to send the asthmatics off to swim.
I know, and a lot of research has been done probably over the last 3 or 4 years, directing asthmatics away from, potential asthmatics or asthmatics away from swimming, particularly if there's chlorine in the pool, because more recent evidence is showing that if you're subjected to chlorine during your developing years, it actually sets up those bronchioles to become irritated. So that's a whole new research area, I know, which is a problem because, as you say, we've always used swimming as the ideal exercise for an asthmatic to do. So we're now tending to steer more away from that.
Given that we've talked a little bit about eligible medications, if a GP is managing a patient who's playing any kind of elite level drug testable sport, how do we find out exactly which things are kosher and which things aren't?
Well, the easiest way, luckily, MIMS has now got that little icon next to all the drugs saying that allowed in sport or not. That's at its simplest level.
In the book, it has that. But when you're using a prescribing program and it pops up the prescription, the logo doesn't pop up. Is there somewhere else that we can search that?
So the ASADA, the Australian Sports Anti-Doping Agency, has got a website, and the WADA, the World Anti-Doping Agency. So if one simply clicks onto that, you know, just bring it up and type in what drug one's using, it'll tell you straight away if it's allowed to be used in sport or not. Okay. So that's a simple resource.
Are there any other very kind of commonly used medications that doctors might be prescribing that you would say, gosh, you know, that would be a red flag for an athlete?
I think the problem that we're seeing more and more frequently are supplements. And a lot of athletes and men in the street and kids and recreational athletes are using more and more supplements and herbal aids and so on. And because none of that is legislated, or nobody needs to prove what the actual ingredients in any of those supplements are, those are a big potential cause of positive drug testing. And that doesn't appear on any site. So if you look up any supplement, they'll all say not allowed to be taken because we actually don't know what ingredients are in it. And a recent study, maybe about 2 years ago, looked at all supplements. It was an American study, but you know, here we can get anything on the internet. And they found that about 40% of supplements that were just normal dietary supplements contained sufficient levels of steroids and stimulants that would result in positive drug testing. So as a blanket rule, for instance, at the WA Institute of Sport or the national hockey team or any of the athletes I look after, the rule is no supplements, not negotiable, end of the story. And we try to get that message out because it tends to filter from the elite professional athletes all the way down to the kids, that if they see their heroes using supplements, they think that's the way to go. So we're trying to educate everybody from elite athletes to anybody who participates in any sport, that as long as one has a balanced diet, sufficient carbohydrates, sufficient protein, sufficient fruits and vegetable, there is absolutely zero reason that one needs any added supplements, and that's as simple as it is.
Yes, I saw a lady this morning who's been taking some kind of herbal weight loss tea, and I'd asked her to bring it in because her blood pressure suddenly skyrocketed, and almost the first ingredient is ephedra. When you look at it, and I thought, well, that will explain the blood pressure. But she was most miffed that I advised her not to take it.
Yeah,
I suspect she still will.
Yeah, unfortunately, we're competing against the natural therapists and equivalents and the advertising agencies, and I've come to the conclusion that I'm too honest in my clinical practice, because I quite often say, we can't guarantee that this management is going to work. We'll try this. If this doesn't work, we'll try that. Whereas a lot of people out there claim that if you listen to me, I've cured everything and fixed everything.
Fix it.
So, yeah.
And your cancer on the side as well.
Exactly.
And we'll come back to their discussion later. But before we move on, we wanted to get some more advice about the use of performance-enhancing substances. We spoke with Dr. Rod Moore about current drugs that people might be taking, the people who might be taking them, and the effects they can have on somebody's body.
Rod, welcome to the program.
Thanks, Olga. It's a pleasure to be here.
Rod, drugs and sport in the news all the time. I guess at elite level, general practitioners aren't involved so much. But what sorts of substances might our patients be investigating for their own use?
I think it's important for GPs to realise that they may actually be seeing patients who they're not aware that they're at elite performers or they're appearing at national competition. There may be particularly young athletes who are subject to drug testing, young swimmers. They may be coming in with something else which is not sports related. Yeah. So I think if ever they are aware that their athlete or the patient may actually be an elite performer, it's worthwhile checking so that they're across what may be banned for them. As far as what agents are now common, it's actually more of a problem for the recreational community than I think in the elite sporting community. There's such information at the elite sporting level that most athletes are well aware of the responsibility, so they're unlikely to be trying to source materials that they shouldn't be using. Yeah. It's more of an issue for the recreational community, for the gym community, and for what we call, I suppose, the wellness community, the people that are looking for things that can improve their appearance and their sense of well-being.
Now I see a few blokes who go off to the gym and who tell me they're taking protein shakes and protein supplements and things that are called Massive, which sounds to me much more like an anabolic steroid. But oh no, we just buy that over the counter or on the net. What might they be actually getting?
There's a significant risk that those substances contain what are banned agents in sport, and that's one of the reasons why, for instance, in the AFL, the sport that I'm most closely involved with, there's a very rigorous program of ensuring that supplements are all kosher. Yep. And about 50% of imported supplements, particularly if they've come from China or the US, about 50% of them have been found to contain banned substances, mostly weak anabolic steroids. DHEA is the most common, as well as a range of stimulants. So there's a significant risk for elite performers who are subject to drug testing falling foul of the regulations if they're using supplements. One of the things which is a problem is that we can never vouch for the veracity of what's on the label. So I say to my athletes, look, if what's in the tin is what's on the label, it's probably safe to use, but we can never be sure, and that's why we routinely make sure that all of the supplements that are used at AFL level come from reputable sources.
Yeah. In terms of our amateur patients who might be buying something off the net, what kinds of effects might we as GPs, particularly in a country area, see happening to our patients, and what should alert our suspicion and to ask more closely?
I think if you're seeing unexpected gains in bulk in response to training and mood disturbances, it's probably the most commonly used agents now, growth hormone and growth hormone releasing peptides. Yep. So if you see changes in...
Those will work orally as well?
Yep. Yep. So if you're seeing changes in skin composition, blood pressure, renal function, liver function, they're all things that should alert the GP to the potential for problems. The other area which I think is increasingly risk for GPs is people who are knowingly using these substances, coming to GPs asking for help in monitoring their use. So they'll come in asking for their hormone profiles to be checked, or for their liver function to be checked, or their renal function. Because people who are using these substances, particularly in the bodybuilding community, have got an enormous wealth of knowledge about the substance they're using, which in most cases far surpasses, their pharmacology generally far surpasses that of the general practitioner.
Yeah.
In fact, most other medical practitioners.
How would you negotiate that with an amateur, Rod? If you were in a general practice situation and you needed not to get your patient offside, but you wanted to make sure that no harm was going to come to them?
I've got a fairly strict policy with recreational athletes or bodybuilders or the gym community to be upfront about that, saying that I won't be involved in the process of monitoring, because I think then you become complicit in what's essentially dangerous and illegal behaviour, and you're actually breaking the law too by using Medicare benefits to be screening, doing pathology tests for what are non-essential medical purposes. So I think there's a difficulty there, and I think if you're upfront with the patient and explain that to them, generally most of them are respectful of that, and you generally won't get into any grief with the patient if you adopt that sort of attitude. So I think the notion of harm minimisation I don't agree with when it comes to the use of illicit substances.
But if you thought that they were doing themselves some harm,
I'd counsel them strongly about the notion
perfectly
that they're
thinking
doing
about
harm.
doing a set of liver function tests
Correct.
or something.
Yeah, if we think that they have harmed themselves, I think then you've got a bona fide medical purpose for it. The other area that GPs may come to grief is that in terms of prescribing particularly drugs like tamoxifen and Arimidex, that you may get requests for them to be using the anti-estrogen effects of those drugs to counter the anabolic effect of the steroid use. So they'll actually come along and ask you for an estrogen antagonist because they're using anabolic steroids.
That would be naturally clanging alarm bells for a GP. There aren't very many blokes with breast cancer around.
They'll come along and routinely, they'll tell you why they're using it, because they'll say they're using a performance enhancer or a booster powder that they've sourced on the net, and they're getting these gynecomastia most commonly, and also because it helps to potentiate the anabolic effect if they can block the estrogen.
And you just say you're not playing?
Oh, absolutely. I mean, I think if you're prescribing for those reasons, then I think that's a basic breach of your medical ethics, and I certainly wouldn't involve myself in that sort of behaviour. I think you're really extending. That goes beyond monitoring them, I suppose.
Yeah. And finally, Rod, you were talking about image-enhancing drugs rather than performance-enhancing drugs as a new label that's being sold mostly on the internet. Could you explain to a GP who hasn't really thought about these things, what would be classified as an image-enhancing drug?
Well, growth hormone is probably one of the most common ones that's used in that regard because of its fat-stripping effect and general physique changes. There are growth hormone releasing peptides which are now marketed, and some of the publicity recently has been about those. In fact, the customs interception of those drugs has increased, I think, 200% in the last couple of years, according to the Crime Commission report, which sparked a lot of interest in drugs in sport and the links between drug use in sport and the recreational community and organised crime. The report that was released in February of this year. And there are several of those substances which do things like reduce body fat, increase skin pigmentation so that you look more tan, look fitter. You still finish up in the coffin at the same time, but you look better in your coffin.
It sounds terrific, but obviously you make a beautiful corpse.
I think there's a downside to the use of these things. There are agents which now are used in the bodybuilding population that are veterinary products, and some of those products have cross-species difficulties. Like there are things that are used in the veterinary industry as feed supplements in Europe that might be safe in cattle but incredibly toxic and dangerous to horses. So one ponders what the effects are when you cross over into human usage. So I think there's a significant potential risk to the use of these substances.
Rod will join us again later in the programme, but for now let's return to our discussion with Doctors Ward and Goodman.
Carmel, there are, while we're talking about things that people drink and things that people ingest, the sports drink is the big thing. I see an awful lot of kids just sipping on Gatorade, Powerade and in fact Red Bull and caffeine-laced pretty much soft drinks. Could you talk us through when you might actually need one of those hydrative drinks?
Sure. So just to get caffeine out the way, caffeine we definitely don't advise for anybody to take.
Yep.
So definitely steer all our athletes, any person who's doing sport at any level does not need caffeine.
Yep.
The downside of caffeine, as we're all aware of, it can cause high blood pressure, it can cause tachycardias, abnormal heart rate, dehydration, among many other things. So if one has somebody who's got undiagnosed cardiac problems and they have caffeine, whether it's a kid or anybody of any age, we know that that can cause major cardiac problems. So the only time we use caffeine in the elite athlete is under very strictly monitored conditions. And it came off the ban list. Caffeine was on the ban list until 2004. And then just before the Athens Olympics, it was taken off the ban list. So then we get pushed into madly trying to find legal substances, ergogenic aids that can help performance. So for instance, with the hockey team that I look after, we really researched for about 2 months before the Olympics. Individually, we measured performance, repeated sprint tests, power, and so on. But simultaneously, we did heart rate monitors, we did blood pressure monitoring, we did sleep studies, we did reaction time. So every athlete, and then every athlete was given the choice if they wanted to use it or not. But certainly we would never ever blanket prescribe it, and that would be talking the 1%er to improve performance. So certainly for the recreational man in the street athlete, caffeine's a no-go. That's in terms of caffeine. So that's no Red Bull, no caffeine containing drinks. I think they're definitely contraindicated. In terms of sports drinks, again, the main thing one needs in the sports drinks are the electrolytes as well as the fluid, because as you know, if you simply take in water, a lot of that doesn't get retained in the system, and you need the sodium, potassium, etc., to actually keep the fluid in the vascular compartment. That's what I explain to the athletes. Does one, in addition, need the extra sugar that one gets in the Powerade, Gatorade type of sports drinks? Again, at an elite level, I would say yes, probably for that 1% again, and I personally push that for all my elite athletes. But again, for recreational type athletes and for kids, I certainly don't think that's necessary. So I would think, if they had water and oranges at half time, that kind of a situation, or had any kind of food added, a bit of extra salt in the evening would be more than sufficient. So very, very important. I do think it's extremely important to keep hydrated, particularly coming into a hot summer. And I don't have a major problem with sports drinks. I know the dentists do in terms of tooth decay and so on, but even they say as long as you rinse your mouth out with water after you've had the sports drink. So if I had to pick the least of two evils, I would rather say they have the sports drink rather than they become dehydrated. And that's probably just going on to one of the major causes of cramps that we see. Muscular cramps is on dehydration, heat exhaustion basis. So, rather than any electrolytes, magnesium, anything like that.
So you don't have a surefire cure for cramps, you reckon prevent them by staying hydrated?
And even then, sometimes after we've done however many investigations one has to do, we still don't find a cause for the cramps. Again, I wouldn't have a problem if we're happy that they're adequately hydrated and they're not getting heat exhaustion, dehydration. Can one add a magnesium tablet? Perhaps, probably won't have any downside. Could it be beneficial? Although research has never shown that, again, perhaps it's something to add. But no, cramps are still one of the things out there.
Difficult things. There's no magic stretch that the patients can do before, during or after to prevent them or reduce them?
Well, cramps probably not. If we're talking about stitches, like diaphragmatic stitches, that's another thing that no one really knows what causes it. We know dehydration can contribute to it, and that's one of the areas that if one's getting tired during exercise, we advise the athlete to breathe in and out as much as possible. So you actually fill your diaphragm, you fill your lungs and empty your lungs, and maybe that helps the diaphragm work, you know, coordinatedly as opposed to not.
Yep.
So again, stitches and cramps is a huge question mark.
Yeah,
We don't,
but
not,
so calf cramps and feet curling up, nobody really has an answer.
no, unfortunately.
Well, cycling gets very popular,
Sure.
particularly when people see the Tour de France.
Yes.
And then they all jump on a bicycle and ride 50 kilometres and come in the next day to the doctor's surgery absolutely crippled.
Yeah.
Do you have any advice for doctors on helping the patients when they're starting out cycling? And are there any particular common injuries that you see?
I would probably say cycling, or as you say, when running becomes popular all of a sudden, or when tennis becomes popular all of a sudden, you get a rush of people wanting to participate. And I think it's just the same basic rule for everything, as simple as not to do too much too soon. So if I had to start anybody off on any program, whether it's running, whether it was cycling, whatever, I would firstly make sure they only do something every second day, because if one's prone to develop any type of overuse injury, if you progressively increase the intensity and the duration of exercise, that helps to prevent it. And probably I would, although the research again isn't out there for stretching, if one looks anecdotally on people who stretch compared to not, they seem to get less injuries. So again, I would encourage someone to do a warm-up and a stretch before just jumping on a bike or going for a run. Build up really gradually, don't do too much too soon. Increase duration before intensity. So, but even the duration, I would tell them to start off maybe with 5 or 10 kilometers, even if they say that's ridiculous, there's no point even getting out my bike for that, you know, little thing. I think if one sticks to general principles, then you can't run into too much trouble.
Yeah. Are there any particular injuries that you see with cyclists?
Well, probably knees. We see patellofemoral maltracking happening, and again, that's usually because they've got stiff, inflexible muscles that they haven't worked on pulling the kneecap laterally, for a simplistic explanation. We see back and neck injuries, particularly if they're sitting in a forward flexed position for periods of time and they're not used to being in those kind of positions. If they spend lots and lots of time on the bike, we see hand ulnar neuropathies. We do see saddle injuries, pudendal nerve pathology and so on. But most of those can be prevented and managed by graduating into activity, or if they do develop any of those neurological symptoms, again, just cutting back on what they're doing and gradually increasing. And, you know, obviously a comfortable saddle is important as well.
Comfortable saddle,
Yeah.
and perhaps
Padded.
starting with an upright bicycle if
Yes,
they're, particularly, I
probably.
guess, if they're older and they've
Yep.
got an arthritic neck.
Sure. That's good.
What about the runners?
Runners, similar situation, you know, particularly people that used to be very fit and healthy and run in their youth and then do nothing for
Do nothing and then
for
decide that
20
they've got to
years.
get fit for the footy team and they've got 3 weeks to do it.
Exactly, that's it. So again, definitely we see lots of, you know, overuse and traumatic injuries. You know, these chaps running around and then falling over, which sounds silly, but I've seen quite a few, you know, fractures, wrist fractures, shoulder dislocations from people who start running and get exhausted and then either go and try and play a team sport, and because they're not fit enough or they fatigue really easily, they actually fall over and get traumatic injuries. But much more common than that would be an overuse tendinitis, usually Achilles tendinitis, classically in an older athlete who hasn't exercised for many years, then decides to get into exercise, again, does too much too soon, and develops a tendon injury or a hamstring tear. Those are probably the common ones I see.
There's a lot of controversy, or at least a lot of information in popular literature about barefoot running.
Yes.
What do you think?
I'm actually not sure where I stand on that. It defies any scientific logic in that we've scientifically measure if someone's pronated, they need to either be in a rigid shoe to get them into a neutral position and or add an orthotic, because we know, we've shown that if one's pronated, that predisposes to injuries. That's at a logical level. At an anecdotal level, I've had quite a few athletes, man-in-the-street type athletes, that have been injured previously, have done all the right thing, keep on getting recurrent injuries, go barefoot running or the toe shoes and have 0 injuries. Can't explain it, and I don't like not being able to explain things, but that's the reality. So I'm not sure where I stand on it. The research is very split. I still go the scientific route if I have to prescribe. I'd still go according to science. But if an athlete comes to me and says, or any kind of exerciser comes and says they feel very comfortable running barefoot or in the toe runners, I say, just try and we'll see how it goes.
Yeah.
So I'm very interested to see where that goes.
I haven't seen any toe runners or barefooters in the Olympics as yet.
Well, exactly, except South African Zola Budd in the day when she was breaking all the world records, she ran barefoot. So there you go. But other than that, exactly. I think nobody's prepared to take a chance, as I say. And if you're dealing with elite athletes, you kind of try and do things by the book, research, evidence-based and so on. But I'm veering. I'm not quite sure where I sit with that. Yeah.
And let's hold that discussion there for a moment. The training regime that professional and even amateur sports people are expected to maintain is becoming more and more demanding as our sports become more and more competitive. We spoke with Dr. Rod Moore to get his thoughts on problems of overuse and overenthusiasm.
Rod, a lot of our patients in our little country towns are busting themselves to train up for the cricket team or to train up for the football team, and they will quite often overtrain in a very short period of time when they suddenly realise that it's 3 weeks to the beginning of season.
As an AFL team, Dr. Olga, I often say to people pre-season is the most dangerous time because there's a big volume of training that goes on there, so sometimes it's actually safer when they get to the games. So you have to be very cautious about the introduction of training. People do too much too soon. There's a whole pile of things that can occur there with overuse injury to tendons, stress fractures, and also potentially cardiovascular risk if people are adopting an exercise regime that they've not previously encountered. So not just for preparation for sport, but for general fitness. So I think it behoves athletes and patients generally to seek advice from their doctors about participation prior to undertaking any sort of unaccustomed vigorous exercise.
Yeah, no, I know a lot of country doctors are in the situation where they'll get a little note from the gym saying needs a doctor's certificate to attend the gym, and quite often those are chronically ill patients, but sometimes that's somebody who's wanting to train up for a specific goal. What sorts of things should we actually look at and measure?
I think one of the first things I would ask the patient is what's their history of exercise been in the past, if they've ever had any unexplained syncope, shortness of breath, obviously all the normal cardiovascular things that you'd look for, and particularly with sport, the risk of sudden death. So anybody who's had a history of sudden death in the family at an early age, I think it always needs to be fully investigated before you allow them to participate in an exercise program,
So
particularly a vigorous exercise program.
Brother or sister maybe dropped dead while jogging, you might look at doing an echocardiogram or something?
I would do that routinely in someone who's had a death of a close family member under the age of 40.
Back in the day, we always used to be told, the first thing you do in your session is stretch, whereas now I understand that we're advising athletes that you can't stretch cold muscles and that they need to do a warm-up and then a stretch. Is that the kind of advice that GPs should be running off?
Yeah, I think that's a reasonable sort of advice to be saying that there is very little scientific evidence that stretching is actually therapeutic, and it makes people feel better, but doing a stretch as part of a functional warm-up. So warming up by doing a little bit of what you're going to do in a game is probably the best way to warm up.
When the patients, as they inevitably will, develop their tendinitis or whatever, how can we help them to a much more rapid recovery?
One of the things, particularly with tendon injury, is to avoid the notion of complete rest, the thing I call the dreaded R word. Athletes and active people in the community don't like to hear the word rest, so I think to have a knee-jerk response to say, I'll just rest if someone presents with Achilles tendinitis or patella tendinitis, or tendinopathy as we probably should properly call it, given that there's a lack of inflammatory cells in these tendons when you biopsy them. I think we should make people look at this, the idea, the concept of alternate activity. If someone's been very active, to actually stop them completely psychologically is bad for them. They don't feel as well. So if someone's been a runner, you may say that they could, as an alternative, do some cycling or some swimming. Obviously for people in rural areas, the winter time's a challenge and there aren't that many heated pools in rural centres. So you try and look at an alternative type of exercise for them, get them to understand the concept that tendons like to be loaded. I think that's very important, that if you rest, tendons denature. You could rest for a long time and still have a problem with your tendons. So it's okay to keep active within the confines of your pain. So if you stop completely, that is actually more deleterious than continuing on with some exercise.
So can you tell them just to put on a brace and get going?
It's, if they're able to function with the discomfort and they're prepared to tolerate the discomfort, they're generally not doing themselves a lot of harm by doing that. Then you would obviously adopt supportive measures like bracing and use of anti-inflammatory gels and maybe injecting it if it's been going on long enough.
Yeah, now
strengthening exercises.
That's controversial. Injections and tendons.
Yep.
Yes,
well,
no, maybe?
In load-bearing tendons, if you're injecting a peritendinous injection in the patella tendon or the perineals, tibialis posterior, Achilles tendon particularly, there's an incidence of tendon rupture, and I'm very, very reluctant to use tendon injections in those sites. I think those tendons with a sheath, where you can do a peritendinous injection into a sheath, is safer. The Achilles tendon doesn't have a sheath, so I'm very nervous about injecting in the region of Achilles tendons, having had a couple of tendon ruptures in the past. So there are alternatives. Steroid iontophoresis is a valid alternative to.
You might have to explain that.
Well,
that sounds...
iontophoresis is an electrical technique where dexamethasone is the most commonly used steroid. You inject the steroid into a dehydrated, desiccated gel patch and set up an electrical circuit with a gel electrode that you place over the area of tendinopathy in it, and it's been shown to be effective, nearly as effective as peritendinous injection without the risk of steroid-induced tendon rupture.
It sounds pretty fancy. Is that available anywhere other than...?
Well, there are self-charged electrodes. They're relatively expensive. Most sports medicine centres would do iontophoresis as a routine therapy. The machine's relatively expensive, and probably, unless there's a sufficiently high demand within your practice, it's probably beyond the scope of rural general practice.
Yeah. Is there any difference when you're treating children or teenagers to treating adults?
True overuse tendinopathy is distinctly uncommon in children. You're more likely to be seeing an insertional apophysitis, things like Osgood-Schlatters or Sever's syndrome. And again, I use the word syndrome with parents because mums don't like to hear the word disease. And it's not a disease, they're conditions of normal adolescent growth and normal adolescent activity. And I think with something like insertional heel pain or insertional knee pain in children, if you rest them, it's going to go away in 18 months, and if they keep active, it's going to go away in 18 months. I actually have on the back of a prescription pad written the word fun, and whenever I ask kids why you play sport, that's always the word that comes up. If it's not the first word, it's in the first sentence. And if kids are still having fun, even though they're hobbling, you're not doing any harm. So it's perfectly safe, in fact desirable for them to remain active.
And things like taping and physio techniques and padding, do they help a lot?
They can all be helpful, and I think that you do those things, but the most important thing for kids is participation. From a peer point of view, fitting in with their peer group, the socialisation aspects of sport, to me that transcends the risk associated with continued participation. It's hard for parents to see their little boy or girl suffering, but if the kid's still having fun, I universally allow them to continue on with their activity.
And Rod, could you comment on compartment syndromes? I noticed that the latest check has got a significant section on shin splints, which I understand is a type of compartment
syndrome. Shin splints is a grab bag diagnosis for anterior or medial shin pain. And I'd like to describe to patients there are three causes of shin pain: shin splints or tendoperiosteitis, an inflammation along the medial border of the tibia at the attachment of the calf musculature. The other cause is stress fractures, and stress fractures of the lower limb bones, usually at the tibia and fibula, usually occur at the junctional areas, junction of the middle and lower third, or middle and proximal third. And the third thing is compartment syndrome. Compartment syndrome, as medical students and young hospital doctors, the ones we see are acute post-traumatic compartment syndromes. Chronic exertional compartment syndromes, completely different entity. Patients there generally will have the onset of swelling and tension, pain in their muscles, which comes on after a period of activity. They have to rest until the pain subsides, and then they can carry on again for a period of time. Anterior compartment, so the extensor compartment of the anterior lower leg is the most common of them. You can also get it in the perineal or lateral compartment and in the two posterior compartments, of which the deep posterior compartment is the most common. It's a relatively, well, it's not difficult to diagnose, but you've got to suspect it, you've got to have a high index of suspicion. And from that point of view, I would always see the patients after an exercise session to get an idea of what's happening with them.
So get them to go hard.
Go and do some exercise, come back and see them, and preferably not. If I'm, for instance, monitoring compartment pressure, I get the patients to come and check that I'm running on time, come in 15 or 20 minutes before their appointment, go out for their exercise sessions so they can come in and literally walk straight through the door and get up on the bed so you can monitor their pressure, because it can go down very quickly. So if you let them sit in the waiting room for 10 or 15 minutes, that may be enough for their compartment pressure to return to normal.
Okay. Now, if we're in a general practice, obviously without a manometer to measure that, what would we do?
I think what you've got to do there is to be conscious of the potential for the diagnosis and arrange for them to see someone who can actually monitor their pressure. Most surgeons who are going to decompress compartment syndrome like the reassurance that the pressure is elevated, and it's a relatively simple test to do with the appropriate equipment.
Carmel, I understand that there are some very fancy gadgets for measuring compartment pressure and finding out if a patient's got compartment syndrome, but you use something much simpler and more familiar to GPs.
Well, I do. Well, given my age, I don't deal with these newfangled equipments, but seriously, I think that unless one keeps the so-called Stryker machines very well calibrated, you don't get an accurate picture. So similar to how I use a normal mercury sphygmomanometer, I do my compartment pressures, as I was taught years ago, which I still think is accurate, using a three-way tap and tubing. So the problem is, or the challenge is, to measure the pressures within a minute of them stopping exercise. Because they usually drop so rapidly that if you don't measure it within a minute of them stopping exercise, the pressures can be back to normal. So we get them as bad as they can possibly get. I get them on the treadmill out back until they're really in agony, zip them in here, and then within 30 seconds really measure the pressures.
Okay, so you've got a reasonably familiar looking setup here.
So I set this up whilst they're exercising on the treadmill. So it's basically a three-way tap connected to my blood pressure machine. I draw up mercury. I draw up some local anaesthetic to form a meniscus, and then have a 20 ml syringe connected. At the moment, I've got the tap closed off to the needle. As soon as they're on the bed, I'm pricking myself, uncap it, put the needle in the compartment that I'm measuring, open the three-way tap, and gradually, put that in the bed, and gradually depress the syringe. And what normally happens is the mercury would go up, say, to 40 or 50 millimeters. The meniscus doesn't move until you get to the pressure that's actually in the compartment. When you get to the pressure that's in the compartment, the meniscus obviously goes down and you see what pressure that was. Simple, nothing much can really go wrong because it's an open system, you're not relying on any kind of calibration, and I found that most accurate. It takes a little bit more work, maybe another 5 minutes, 2 minutes compared to using the automatic Stryker machine, but I found it most accurate.
And Rod, is a surgical decompression the treatment of choice?
It's basically when patients get to that point that it's stopping their exercise, that's the only treatment which is going to make a difference. Most of them don't want to face the alternative of cutting back or doing a different type of exercise. So if someone's a runner or a footballer or a netballer, that's what they like to do.
They've got their heart set on the Boston Marathon. They've got their heart set on the Boston Marathon.
Well, most marathoners have got smaller legs. They tend not to be the people who get compartment syndrome. One of the giveaways is if you look at patients and you get an idea about their anthropomorphic shape and get a mental picture of how big their calves should be. When you look at them, people with compartment syndrome almost always got calves which seem bigger than they should be. And some runners have that, but most runners that are more asthenic, sort of slimmer build. It's the occasional runner who's more likely to get the compartment syndrome. One thing I would say, particularly for rural practitioners, I wear another hat as a member of MDA National, so medical indemnity insurance, and we've had 2 cases, both in rural practice, where patients developed acute on chronic compartment syndrome, and they weren't diagnosed, and they were given increasing doses of narcotics as inpatients in hospital because of severe leg pain. They both developed extensive muscle compartment necrosis as a consequence of the failure to recognise compartment syndrome. So it's potentially more than just an annoyance. And both of these patients had exertional compartment syndrome, which turned into an acute surgical emergency that were not recognised, treated with narcotics because of increasing pain, and required eventually debridement of necrotic muscle components with long-term disability. So that's a rare event, but it's one that if you are at all suspicious of, requires urgent care.
Right, well, thanks very much for that.
I'm sorry to finish on such a cheerful note.
It's a very cheerful note, isn't it? But thank you very much for the information.
It's my pleasure. Thank you.
So physical activity is critically important, but has its own problems if people don't engage sensibly in their exercise or sport. Dr. Carmel Goodman joins Dr. Olga Ward again, and this time she gives us her thoughts on the cost and benefits of exercise for those with chronic diseases.
Carmel, it seems that for a lot of patients in a general practice setting, that they may have some underlying chronic problems, arthritis or their asthma or their diabetes or something, but we're always advising them that some more exercise would be a good thing for them. They are almost invariably the patients that then come back to us with a large number of injuries of various natures. Where do we kind of pitch it so that the amount of benefit that they get from the exercise exceeds the number of injuries that they get from doing it?
Sure. So overall, I don't think there's any doubt that the benefits of exercise far, far, far outweigh any potential negative effects. And we've all seen the evidence, conditions, you know, cardiac disease, diabetes, asthma, arthritis. More and more research has been shown recently, depression, mild and moderate depression, how many athletes can come off their antidepressants if they start an aerobic exercise program. So that's a given. I don't think there's any controversy about that. The challenge, I guess, is to get them exercising at a level sufficient to give them that cardiovascular benefit, but not get them injured. And that really isn't difficult to do. I think, again, if one sticks to starting off really slowly with an exercise activity that doesn't cause any pain is the way to go. So for instance, if we're talking about somebody who's got really bad, an arthritic, really bad knee, hip and ankle arthritis, obviously walking or running is off the agenda for them. Cycling, a lot of patients with reasonably severe arthritis manage on a stationary bike. I'm a huge believer in water work at whatever level. So even, and I tell a lot of patients, just go down to the local pool, slowly walk up and down in the shallow end. You're getting the cardiovascular benefit. You're not getting any, you know, downside from that. And then if one wants to graduate, you go into deeper water. You know, they can do a bit of water walking, either deep water or shallow water, and you hardly ever see injuries from water work. And even if, you know, one doesn't want to pay for going to the local pool, if one can't afford to, I certainly know around here there are lots of beaches with flat water, the marinas and so on, where they can simply walk into the water waist deep and exercise there. So certainly for arthritis, I think any
unloaded exercise
is absolutely perfect to do. And for the rest, again, depending, I always say what exercise they enjoy, whether it's in a gym situation, whether it's walking around the block, you know, walking on an oval and cycling, as long as one starts off really gradually, and I would normally say for instance, just 10 or 15 minutes every second day, stick at that level for 2 weeks. If you don't have any problems with that, the rule that we've said for years and years is not increasing by more than 10% per week. I go even further than that. I say increase by 10% every 2 weeks. And realistically, you can't run into too much problems with that. So, you know, I think the potential benefits far, far, far outweigh any potential downside.
I also hear that many light repetitions is a good idea rather than immediately going to a heavy weight.
Yes, but not many light repetitions. So again, I would start them off literally on 3 repetitions of an exercise and maybe introduce 3 new exercises per time of literally 3 repetitions of each exercise. So I'm extremely conservative starting off any exercise programs, because otherwise it's inevitable that one's going to run into injuries. But if you're very, very, very slow and conservative, you'd be unlucky if one ran into injuries.
Thank you very much for helping us look after our patients, and thanks for joining us.
That's a pleasure. Good.
So the benefits of exercise far outweigh the cost, but there are some people for whom engaging in exercise is incredibly hard, no more so than those suffering from COPD. We visited the Swan Valley District Hospital Pulmonary Rehabilitation Clinic and spoke to some of the patients about engaging in exercise and the problems and benefits that they see.
I used to be a roofer, which very physical job. Now I can't do anything because of my condition.
What gets you too much is walking around, you know. I get about 300 metre walk, and that's my limit, you know.
I worked 80 hours a week, grandkids running around all the time, looking after my dad, running a house, garden, a lot. Now I can do not much at all.
I have trouble motivating myself for sure. I live on my own, which makes it pretty hard anyway. Trying to get yourself up and doing things, it's just so easy to say, I won't do it. I can't do it.
Okay,
and
that's fine.
You just go backwards.
There, catch your breath, and when you recover, you can do something else, okay?
It's just generally being motivated by the fact that you've got people here pushing you around. In other words, you're trying to keep up with yourself while you're doing it. I like to push myself too much sometimes, but at home one's apt to sit by the telly, aren't we? And watch the telly and think, oh, I should go and do something, but I don't think I will.
Oh, I'd sit in the morning, come up with about 1 million excuses. Yeah, like, oh, I'm sick, I'm out of fuel, I've got a flat tyre. Get over it, get in the car, get here.
The littlest things you just don't realise, opening cans and jars and things like that. I was really struggling, I couldn't do it, you know, it's ridiculous. I'm only 57 and it's just ridiculous. But now I'm starting to get a bit of that strength back, which is great, you know, because you can't do things like that, your independence is gone.
Well, when I first come out of the hospital with double pneumonia, they sent me to here. Well, you have to walk 20 minutes. Well, you just can't when you first come out. So I tried, and each week you come, you feel as though you're getting better. You feel, no, I won't stop, I'll keep going for another one. And the girls are there to egg you on. If you were at home, you wouldn't do it. You wouldn't do it yourself.
Breathing's wonderful. It's a bugger when you can't. Excuse the vulgarity. You can't. I used to have a sticker put out by the Lung Foundation I like. It says if you can't breathe, nothing else matters, and that's about the size of it, isn't it?
Do 5 today, and then we can build up again, okay?
Well, they're going to give me a lung transplant 7 years ago,
and they reckon I was too old. They knocked me back. Yeah. But this exercise program sort of kept me going anyway.
And the others keep you doing it too. It's the fact that you're here with a lot of people and you're really trying, isn't it, to keep up with them. Otherwise you just, some of them give up and they don't. They don't keep up, they just disappear.
Yeah, I can do my household chores and stuff at home a lot easier than I could before. I'm laying bricks at home at the moment. Yeah, I'm building a brick wall and a barbecue. It takes me a while, you know. I just sit there near with my oxy and play around, you know. I might lay about 20 bricks in a day and that's about it, you know.
I'm lucky I'm not on oxygen, and this is, I think, is what's keeping me off oxygen, because I tried too hard when I'm here, you know, and I love coming. Now and again they put you off for a few weeks. Well, you really do notice it. You think to yourself, I will do this at home, I will do this, but you don't. And you can feel yourself and your muscles getting wearier. So when you do come back, like if you have to come in for pneumonia or anything, they bring you straight back. But I've been here quite a while now, and I'd hate to be put off. I love it because it's keeping you going, keeping your body going, your breathing going, your muscles going. It's great.
Obviously it works. Hate to admit it, but exercise keeps you alive. Damn it.
Thanks, you guys. See you, Irene. Thanks for coming today. We'll see you Monday.
And a big thank you to all the staff and clients who allowed us to come in and talk to them about their pulmonary rehab, and to everyone at Edith Cowan University and WA Health who were involved in the production of that item. And also a big thanks to our guests, Dr. Carmel Goodman and Dr. Rod Moore, for their time. Now, there are some good resources available that you might want to take a look at. For instance, the October unit of CHEK focuses on sports medicine, and the GP Learning case of the month for October looks at shin pain in a football player. We'll put the links to those up on our website, that's ruralhealthwest.com.au. And while you're there, remember that you can review this program or any of the others going back to 2009. Well, that's it from us for 2013. We'll leave you with a quick message from Rural Health West's CEO, Belinda Bailey.
Hi everyone. I just wanted to take this opportunity to acknowledge and thank all the people that have contributed to the Rural Doctors broadcast in 2013. It's been a fantastic year of broadcast with really varied and interesting topics. A lot of people have put their time in, and I'd really like to thank them. I hope you've enjoyed them, and I hope that you're going to enjoy what's coming up in 2014. 2014 is going to be a big year for Rural Health West. It's our 25th anniversary, so we've got a lot in planning, but obviously what we have always got in planning is a suite of fabulous educational services, hopefully designed to meet your learning needs. So 2014 will bring our Rural Doctors broadcasts, we'll bring our regional workshops, which you can take advantage of, because a lot of them are close to home, and of course there'll be the usual conferences that are held in Perth. You'll find information about all of these events on our website, and we have a specific calendar which highlights all the regional workshops around emergency upskilling and all those regional courses. So please get on the website and have a look and see what's of interest to you. The annual conference in March, our signature conference, where we will be doing a lot of celebrating around the 25th anniversary, is an event that we'd love to see you down in Perth for, and your spouse and your family. So please go on the website, look at the dates, start planning now, because we'd really look forward to seeing you. On behalf of the board and the staff at Rural Health West, thank you for the fantastic work that you do out in rural Western Australia. We think about you all the time, and we acknowledge the situations that you're working in, and if there's anything we can do to help you, please don't hesitate to contact us. And on behalf of everyone, we hope you have a fantastic end of the year and a really fabulous Christmas, and we'll see you in 2014.